Hello everyone, I'm Maura Malpetti, I'm the speaker of this session, but before diving into the science and the exciting part, I have some housekeeping notes here. I will give a talk around for 40 minutes, and then so if you get some questions, there will be a question and answer session at the end of the talks. So if you have some questions and you put the hands up, I'm not the rude person ignoring you, but they asked me to... Oh.
It's quite hard to hear you.
Oh.
We hear a lot of sound.
Oh, really? Uh-oh. Uh-oh. Ah, this one. Can you hear me better? Yes. Yes, excellent. So I was saying that there will be a Q&A session at the end of the talk. So if you have some questions, just keep them, because the event is recorded, so the instruction is that you will be recorded at the end while asking questions. We'll do our best to address as many questions as possible, but I could speak about this for 3 hours, but at some point in the background they will cut me, so I'm sorry already if I cannot answer all questions. So I'm Maura Malpetti. I just introduced a bit myself. I'm a Race Against Dementia Alzheimer's Research UK Fellow. These are two charities specifically funding research in dementia, and we can speak a bit more about Race Against Dementia actually later. And I'm also an emerging leader at the UK Dementia Research Institute. And also for some of you who have been part of colleges, I'm based in Sydney Sussex College. Today I will give you a bit of an introduction of brain inflammation in this race against dementia. So this is the topic that I work on with my lab and my team here at the University of Cambridge. And we think that we are after something in terms of possible treatment target for dementia. So just to start from the facts, like the background. In terms of dementia, when we refer to dementia, we speak about over 55 million people and families who are affected by this illness. It is not part of normal aging, and it's something that we stress quite a lot because, of course, if we capture the fact that dementia is an illness and a pathology, we can also thinking about a cure and a treatment rather than just waiting for the best. Dementia can occur also in early life, not just in late life. In fact, in our team, we look at people with dementia who develop the disease around in their 40s and 50s. And also every day, almost 600 people in the UK develop dementia. It is one of the leading causes of death, especially for women in the UK, and the cost per year is around 30 billion. So it's a tragic situation in terms of families involved, society, economy of the country. So we really need to fix this issue. For who is not super familiar with the term, very often we think about dementia as a person who is not able to remember anything anymore, or just missing memories. But actually, dementia is a much more complicated spectrum of diseases, and it's not only memory loss. Like, for example, this is a good representation of what dementia can do to a person. This is William Uthermohlen. I'm not very good with these names, but he was a painter, and he got a diagnosis of dementia in the 90s. And as you can see, there is a self-portrait on the left of how he represented himself, and he was a pretty good painter back then. And then after the diagnosis, you see how he loses the perception of himself and the visual spatial concept of a human face. So it's not just memory. In fact, dementia is an umbrella term used to describe a range of symptoms associated with cognitive impairments. These can involve memory, as we said, language, personality, behavior. People can become aggressive or very apathetic. They can lose the comprehension of words or the way of producing words. And when you hear speaking about Alzheimer's disease, is just one of the causes of these symptoms, which is the umbrella term for dementia. But there are also other diseases behind dementia. It could be vascular dementia, which is related to cardiovascular issues in the brain, Lewy body, and frontotemporal dementia, which are related to different pathology and proteins involved in the brain. In particular, in my research, I focus on frontotemporal dementia, and this is a bit rarer than Alzheimer's disease, but maybe you heard about this term because Bruce Willis, the amazing actor, actually came out with his diagnosis last year, saying that he had a diagnosis of frontotemporal dementia. And this is in particular is a disease that changes the behavior and the way of expressing their feelings and acting in the society. Another person with dementia actually was Robin Williams, and he had a diagnosis of Lewy body dementia, and he was misdiagnosed for many, many years actually with a depression syndrome that was not immediately captured as dementia. And this is still the reality for many, many families, that they go through a lot of different diagnoses that actually they are not correct. So just to speak a bit, we spoke a bit about the symptoms, but I want to dive into what happens in the brain with you. So when we speak about dementia, we refer to the diagnosis and the symptoms, so what actually the person show in terms of changes in their behavior and memory and other cognitive performance. But there is a long cascade of events behind these changes and symptoms. In particular, there is a brain shrinkage, so the cells in the brain dies, and so the brain tends to lose volume. And behind that, also there is an interruption in the connection and communication between these cells before they die. And even more upstream, actually one of the real causes of why these cells dies is that there are junk proteins, garbage, little bits that accumulate in the brain and kills the cells. And we're trying to understand why these proteins accumulate, because in general these proteins are proteins that are functional in normal aging, but at some point they change form, shape, and they start to just kill the cells. And we are trying to understand why. And another aspect that I will dive into a bit more is the inflammation, but I will tell you a bit more later. And of course, even more upstream, we have genes and environment. So very often, most of the cases are not related to genetic causes, but there are some genes that actually contribute to the risk of dementia in the population, and environmental factors like the lifestyle, diet, how people sleep, so many interesting factors that actually they could be a bit modifiable during our lifetime, and we can adjust to reduce the risk of dementia. So for our research and also in the clinics, we use in particular brain scans to look at real life what happens in the brain of people with dementia. In particular, we use these two techniques called PET and MRI, and probably some of you here in the room had an MRI for a knee or like a broken, I don't know, a piece of the body, but it is very similar to what we use for brain, and we just focus on the brain. These scanners look very similar, if you look, like basically the person just lie down inside, but actually they give very different informations. So on the right, you have the MRI, and we use the MRI to look at the anatomy of the brain. So you can see a picture of one of our participants, and this is like basically an image cut down like that. And we are just looking at measuring the size of the brain, and we see if everything is fine. While on your left, there is a PET, and this is a very powerful tool that we use to look at change of molecular changes in the brain. In fact, we use a dye that is injected in the blood. The dye goes into the brain via the blood, and then it goes and targets these proteins that we are interested in, and so we can capture where and look where in the brain these proteins are. So just to give you an example of how we use these techniques, this is a picture of a control, so a healthy volunteer in late life. This is a pretty nice brain. It's like, you have to imagine that is like, you look at that in the front, that these are, I don't have a pointer, but maybe you can see this. No, you cannot see it. But you can see the little ears there. And like the one on the left is quite a healthy brain, is full. While if you look on the right, the brain is dying and is missing pieces. So if you see like little holes that are like a bit more dark, it means that the cells are dying, and so the volume is reduced. Another important thing is actually that sometimes when people come to clinics, they manifest symptoms based on where the change in the brain happens. So, for example, for frontotemporal dementia, it's called like that because the part of the brain that is involved is this frontal part and the temporal part. And the frontal part is where actually our personality, executive function, the thinking multiple things happens. So if it is affected, if cells die in that part, they manifest those symptoms. But this can be also similar in other conditions, like, for example, a tumor in the same brain region. So looking at the brain with these techniques, we can exclude other causes of the symptoms rather than dementia. Then we have PET, and basically with PET we can look also, we mentioned that cells communicate with one another, and to do that they eat sugar. So we can look at the sugar consumption in the brain. And in general, in people with these diseases, like frontotemporal dementia and Alzheimer's disease, there is a reduction of the consumption of sugar. So as you can see, the healthy adults, the signal, higher signal means, the regions, red and orange regions means higher signal, so more consumption of the sugar. And as you can see, there are specific regions that looks actually blue, which is basically lack of signal. And very interestingly, if you look at Alzheimer's disease and frontotemporal dementia, they have a reduction overall, both of them, but in different regions. And again, based on the regions that the brain is affected, they will show different symptoms. So Alzheimer's disease is mainly memory and orientation, like a spatial orientation, while frontotemporal dementia, again, is this behavioral aspect. Also, we can look at those specific junk proteins that I mentioned, and all diseases have different proteins, which makes even more complicated to find one cure for all. As you can see, this is something that we call amyloid PET. Probably you heard in the news, the last 2 years has been quite exciting in terms of new treatments. And maybe you heard the anti-amyloid drugs. And this amyloid is one of those junk proteins that accumulate in the brain, but not in all people with dementia. So when you hear in the news, we have the cure for dementia because we target amyloid protein, is actually working just in people with Alzheimer's disease, not other type of dementia. So as you can see, like again, red and orange is high signal, so more of the target that we are looking at. And in people with Alzheimer's disease, we have this protein, junk protein called amyloid, while in frontotemporal dementia, we don't have it. And this is very important for us, looking at the people in the brain, because if we have a drug that targets that amyloid, we cannot give that to everyone, because it would be completely useless to give that drug to someone who doesn't have that protein, and it could be actually harmful. So just to basically move back to this cascade of events. And this happens for many, many years in the brain before manifesting symptoms. So we actually showed that these changes in terms of proteins in the brain accumulating and inflammation can happen 10 to 20 or 30 years before actually the first symptoms. So it's a very long building up of toxicity in the brain. And for that reason, it's very important thinking how we can change our lifestyle to be able to reduce this risk in the long term, not like just exercise for 2 years or when we are a bit older. It's something that we need to build up in the life. And we are trying to look at these changes with the PET imaging, especially early on, to be able to stop that cascade before it's too late. Because if we stop the cascade at the point of junk proteins and inflammation, maybe we can prevent cells to stop communicating with one another and eventually also prevent the cells dying and ultimately prevent the symptoms. But it's also very important to try to identify who are the people that can benefit most or go for early detection to try to change things, and once we have good treatments also act early on. So something that we focus very broadly in our lab, in our team, is brain inflammation. So you have to think about brain inflammation as an activation of the immune system. So when you think about the immune system, We have been quite exposed to the immune system concept with COVID, like basically the immune system is trying to fight against viruses, anything that happens in the body. But very especially, we have also an immune system just in the brain, and it's completely different from what we have in the body. They communicate, but one is peripheral and one is in the brain. Of course, because the brain is one of the most delicate organs that we have. We need a specific system there. Unfortunately, we cannot see that in the human eye, with human eyes. Like if you think the normal immune system, the body immune system, we can see that in action when, for example, we cut our hand and then is swollen, hot, and painful. That is the immune system trying to fight what happens there and try to reconstruct the tissues. Everything similar happens also in the brain. So part of the immune system, when we speak about the immune system in the brain, we speak about specific cells. Doesn't matter the names, but in particular, if you're curious, we look at something called macroglia cells, and they are very functional cells, and they are like resident in our brains. And when something happens, it could be a virus or any other attack, they get activated and they change shape, change chemistry, and try to reduce the problem. The problem in dementia is that this system, of course, when it's healthy, there is an activation and then you go back to normal. Like, for example, there's an activation in the hand, then when it's cured, it's back to normal. In dementia, this activation doesn't stop, is prolongate and becomes chronic. And this, of course, is harmful and goes against, actually, the cells and kills the cells. How do we measure inflammation in the brain of people with dementia? Our PET, the tool that helps us to measure this. As you can see, again, higher signal, now you are expert by now, a higher signal is red and orange. And as you can see, these are 2 volunteers with different diseases, and they have like high regions of inflammation in the brain. So again, the frontotemporal dementia is more localized in the frontal lobe, so basically in front of the eyes, while the Alzheimer's dementia is more in the back. What we see systematically is that this inflammation is common across all dementia. So this is a big difference in comparison to the proteins. I said that there are proteins that are specific for different diseases, like Alzheimer's disease have amyloid, but frontotemporal dementia doesn't. But actually, inflammation is common across all these diseases. They change the regions, but it is present across all of them. This makes inflammation very important to study, because if we find something that works on one disease, maybe we can apply that across all dementias rather than just stop at Alzheimer's disease. So in our study, we look at different people with the same disease, like frontotemporal dementia, for example. And as you can see, these are 2 different people that came for our studies. The top one has a little bit of inflammation, not much, but is there in the frontal regions, as indicated from the yellow arrow, while the person in the bottom is quite inflamed, so higher signal. And we look at systematically how they perform over time. So we scan these people at visit 1, and then we follow them up for 5 years to see how their thinking performance was doing over time. What we saw is that those people with high inflammation were those people that decline much faster. So like having high levels of inflammation means that steep line means like that their performance dropped over time, much more than those people with low inflammation. And of course, I mentioned that there is a long cascade of events, and in general, when people come to clinics with symptoms and we provide a diagnosis, is already at the time of the manifestation of the disease, and something that you can do after that is just seeing how they decline over time. But what we are trying to do is going a bit earlier, trying to look at when the symptoms start, not when it's already overwhelming at the point that they go to clinic and say there is something wrong here. But also we want to do one step back and look at the phase where they are still symptom-free. So in the brain, there are already changes, but the people don't manifest the symptoms yet. How we do that? Like, basically there are some, I mentioned that most of the cases are sporadic, or for sporadic we refer to something that is not defined by a specific genetic cause, but actually a small percentage of people with dementia, they have a genetic cause of dementia. And this gene, faulty genes run into the family. So if someone comes to the clinic and they manifest specific symptoms and history of dementia in the family, and we suspect that could be genetic, we test them for these genetic mutations, these faulty genes. And if they have a positive test, then we offer the same test to children and their sons and daughters. Some of them wants to know. Some of them don't want to know if they are positive, because if they are positive, there is a high chance that they will develop the same type of dementia that is running into their family. Some of them comes to our studies without wanting to know or with knowing if they are positive, but if they are positive, this means that we know that we can predict that eventually they will develop the dementia, so we know that already in their brain is happening something even if they are not manifesting the dementia. So we can look at that phase of symptom-free when there is this gene in the family. And what we saw overall is that at the moment of the phase of the symptom-free, the cells are still very healthy. So if you look at the brain on the right, the cells, actually, they are still there. There are no missing pieces in the brain. But actually, inflammation is already present. This means that actually inflammation is before, we confirm that inflammation happens before the cells die. And again, going back to that cascade of events that we want to stop, if we stop inflammation, potentially we can prevent cells dying and manifesting the symptoms. So like I show you a bit of the results that we had and why inflammation could be a target for treatments. So there are preclinical studies with mice or like in post-mortem tissue showing that inflammation is present in dementia. There are genetics and also clinical studies that I just show you pointing to inflammation as a key mechanism in frontotemporal dementia, but also other dementia across all the spectrum. We show that inflammation is a main driver of clinical decline. I show you that steep change for people with high inflammation. And the good thing is that actually there are already therapies targeting this immune system in other diseases. If you go to cancer, multiple sclerosis, other diseases, actually they are already targeting the immune system. So why maybe don't look at, the solution maybe is looking at these other fields and trying to bring something that is already present, repurposing these drugs for targets that are in common. But actually it's very complicated because the immune system, we need the immune system. We cannot shut down all the immune system because we need to fight against COVID or other viruses. We cannot be immunodepressed. So our research at the moment is try to understand which part of the immune system we can slow down, which time window we need to act, so when do we need to slow down? Because sometimes the inflammation can be protective, sometimes can be harmful, which part and when we need to do that, and also who are the people who can benefit most from these treatments. To do this, of course, we need scalable markers. So I show you this powerful tool, which is PET imaging. But PET imaging is not present across all the centers. We are lucky enough that in Cambridge we have very good technologies. We can offer this to to people coming to our clinics and studies. But actually, this is quite expensive. Just to give you an idea, a PET scan can arrive to cost between £6,000 to £10,000. So it's quite expensive technique. It's a very powerful one because that gives you the precision of one person being scanned and we know what happens in the brain. But we need scalability, of course. And also we need to learn more about the interaction between the central and the peripheral immune system because, of course, they talk constantly. So it's very important to understand this bidirectional communication. And also we need to study multiple targets, so not like looking only one protein, but many of them at the same time. So to do this, we are trying to basically translate what we see with brain scans into simple blood tests. So this, of course, can really scale up our studies and our understanding of the disease. So I mentioned like the immune system, as well as macroglia in the brain, which is the main cell involved in the immune system in the brain. We have also immune cells going into the brain, into the body, and we can capture that, for example, in the blood. There are different immune cells like T, B cells. There are very weird names, but there are many different types, and they do different jobs. And how they communicate is with chemical signaling that are these molecules called cytokines. And they shoot one another, these cytokines, to communicate and activate one another. So in dementia, there is a storm of cytokines because there is so much going on that actually there is elevated levels of cytokines. And now we can measure them in the blood. So when we speak about cytokines, it's a very complex system. There are like hundreds of cytokines that we can capture, and you have to consider them as an orchestra. Basically, there are a lot of different signaling going around, and it can be very confusing if you are trying to remember all of them, capturing all of them. But actually, as an orchestra, they work beautifully together when they function well. So when the cells and the signaling works, there is a beautiful music. But it's enough that just a sub-part of this orchestra doesn't work properly, and then there is the wrong message, the wrong music, and everything falls apart. So what we are trying to understand is which part of this orchestra is not working. So maybe we can actually fix that, and the music is back to normal. Just to give you like an example of a very exciting new results, we look at the cytokines in the blood, and we identify these list of cytokines that actually they are upregulated in people with dementia. So in this graph, every dot is a participant. Like on the left, you have healthy volunteers, and we always compare our patients with healthy volunteers as a control group. So basically, the normal level of inflammation. And then on the right, you have the two groups with different types of dementia. And there is an upper regulation of these cytokines. Very, very importantly, they are not just there flying around with high levels, but actually those people with high inflammation were those people unfortunately dying quickly. So we identified that people with high inflammation in the blood were surviving around 18 months less than people with lower levels of inflammation with the same type of disease. This opens up a lot of possibilities because, of course, if we can translate from brain scan into what we know in the blood, we can scale up our research. We don't need to stay just in Cambridge or in other centers with PET, but we can go wild and trying to identify people across all communities and provide just a simple blood test. So we are very excited to start this year. We just started this study called Open Network for Frontotemporal Dementia Inflammation Research, or OnFire, which is a bit easier to remember. And our idea is to move from local studies based on just in Cambridge to a UK-wide population. We want to move from PET imaging to scalable blood tests. And we also want to move away from just research centers, but actually involve all healthcare settings like GPs, small communities, everyone in the country. And of course, GDPR are very important in this kind of studies and multi-center studies. So we are partnering up with Dementia Dementia Platform UK or DPUK, and there is like a nice website, and you can look at that to hear a bit more the studies across all the UK. To basically, they have already the best practice for exchanging data across research studies. So just to give you an example of this study, we have already 22 centers across the country who sign up for this study, and they are very keen in collaborating with us. So we are aiming to recruit 1,000 participants across the UK with ethnic, genetic, and socioeconomic diversity, so going into the communities that in general, they are not even offered to participate into research. So we are trying to go in small communities as well. We have local dementia clinics and patient group, supporting group partnering with us. And also we are trying to involve the public and the people living with this disease in the design of the study. And we are also trying to raise awareness about dementia. So we are trying to go and, in town halls and speak a bit more about these conditions and the study. We are trying to do this looking at a blood test for inflammation, but basically all these centers will send samples to Cambridge. We will analyze here with the best technology that we have, and then we will share the data back. So everyone in the country can analyze, not everyone, but like people affiliated with these research centers will be able to have new ideas and apply their new ideas to the data. And we will also freeze some of the blood because, of course, this field is so fast. Every year we have new markers, new exciting things that we didn't know the year before. So if we have like stored blood, and you have to think, like we don't store them in a normal fridge, but we have like minus 80 degrees freezers in our basements, and they can be kept for 10, 15 years, these blood samples. So if in 5 years' time there is a new markers that we didn't consider, we can go back and defrost the blood and test new things. And of course, this will allow us to follow up people and the families over years and see how they are doing. And then also, as I mentioned, share the data. Very exciting for this research. My research is funded, I mentioned, by Race Against Dementia. For who is not familiar with this charity, it's a very exciting initiative, actually, that was funded by Sir Jackie Stewart. I don't know how many people are passionate with Formula One here, but he is a three times world champion of Formula One. He was driving in the late 60s, early 70s, and he was amazing. Basically, he changed the sport because he was really revolutionizing the safety and the protection things, like measures in this sport, because people were dying, and after his fight, actually people stopped dying in this sport. And he's trying to do the same with dementia. So he's trying to make that revolution in changing the pace rather than taking 30 years to get a result, trying to be a bit faster and getting results. Everything started because Lady Helen, his wife, got a diagnosis of dementia a few years ago, and he was very discouraged hearing that there are no treatments. So he's trying to change the pace, finding new ideas and new studies. So it's like I had the fortune of sitting in one of the winning cars and trying to learn a bit more from him about this mentality. And also, as you can guess from the accent, I grew up in Italy, and we grew up with pasta, Schumacher, and Ferrari there. So when I saw the call of this funding, and it was Formula One and dementia research, it's like, oh, amazing! It's amazing. So if you don't know the charity, really, there is a beautiful website, and they explain how they think about dementia research. And of course, when funding starts, someone is a catalyzer, and we just got announced 3 days ago about another big funding that we got from the Kissick Family Foundation and the Milken Institute. They are US-based funders, and they decided to also fund this study in the UK. So we are ready to start, and hopefully, maybe next year we'll be back and show you the results, but we are very excited about this study. So just to summarize, the take-home message that I hope that you can go home with is that we have very good brain scans, and that we are focusing on the changes in the brain rather than just looking at the symptoms, because we want to go early enough to stop the disease before it's too late. And so we are trying to change that, looking at inflammation as a potential new target. We are not just using imaging, but also we are using blood tests to make the research democratic, and also trying to reach all possible different populations and trying to learn from the diversity of different ethnicities, different socioeconomic status, etc. And we are trying to combine these techniques to identify who can benefit most from treatments, when we need to act, and which part of the immune system we want to switch off. And we really hope that also with the mentality of Formula One, and give also the urgency to people, is that treatments will be available sooner than later. And also, I hope that everyone in this room will go home and start to discuss a bit more about dementia with everyone that you meet and speak with, because I think part of the journey to arrive to fill in that gap between our studies and actually very good treatments is raising awareness and the knowledge about this disease, thinking that it's not just normal aging, but actually something that is wrong in the brain that we can try to fix it. So thank you so much for your attention. I'm very happy to answer any question here with the microphones. They told me that we need to wait for the microphone. But if you want to hear a bit more about our research here in Cambridge, that is our website. Alzheimer's Research UK is an amazing source for more information about Alzheimer's disease and dementias in general. And of course, Race Against Dementia if you want to hear a bit more about the charity. Thank you.
I've been told that the incorporation in our diet of things like rapeseed oil and palm oil, which aren't normal foods in themselves, and which require substantial pesticides to rot down to make them edible by humans, has caused, that's what I was told by the consultant, that a lot of the immune problems which relate to things like multiple sclerosis and Crohn's and IBS and everything. Do you have any comment about that in relation to dementia? And also, can you comment on the fact that back in the day we used to think, well, we used to be told that there was a link with cheap metal pans causing dementia. Is there anything in that?
That's a very interesting question. So I think we need to start from scratch. Basically, in the past, because like dementia for many, many years, it was thought to be, like even just something related to the mind rather than the brain. And then we passed that first step. And now we know that the body and the brain actually communicate quite a lot. So everything that we eat is impacting the brain. And in general, also, every time we say, like, if you keep your heart healthy, you are keeping also your brain healthy. So doing exercise, like not eating too much fat, etc., etc. In terms of diet, there are different studies. It is very cloudy, as like trying to understand the pesticides, the metals. We don't know really if there is a causal direction. So like if actually it is one of the causes. We know for sure that eating healthy helps in keeping healthy both the body and the brain. So for example, there are studies on this Mediterranean diet, how this helps to keep, like for example, cardiovascular issues low, and this helps to not have, for example, vascular dementia. But there are not like one-to-one causal direction in terms of these other products. But yeah, definitely there is a factor that if you eat healthy and good food, that helps. But yeah.
Thank you for your talk. You mentioned lifestyle, diet, and how we sleep. Is there anything you can recommend we do to help ourselves?
Yeah, sleep is always a tricky topic. Basically, what people suggest in terms of studies is like that skipping sleep, like sleeping too little is not good for the brain, because during the sleep, I know, like especially like there are a lot of people, like they are forced to sleep little because they have too much work, stress in life, etc., etc. Basically, sleeping too little doesn't allow the brain to clean up the proteins in the brain. So as part of the sleep, there is a lot of different things happening during the sleep. We don't know everything, but we know that, for example, there is a consolidation of the memories. So if you sleep, like during the sleep, there is consolidation of the memory. There is also a cleaning of the junk proteins, let's say. So sleeping too little doesn't help those aspects. Actually, some other studies show that actually sleeping too long also is not healthy. So the suggestion is having like a equilibrate and balanced lifestyle, like basically trying to, being consistent with your sleep, like trying to, sleep enough but not too much. Is like, is very also personalized. But yeah, it seems that more and more people that have a disruptive sleep doesn't help the brain coping with things. No.
Thanks. That was a really interesting discussion. If you met somebody who was in the early stages with symptoms, and based on all of your expertise and knowledge, you had to put together a plan, what would that plan be?
That's an excellent question. So just to clarify, I'm not a clinician. My background is in psychology and neuroscience, but I work very closely with clinicians in our clinics. Basically, I see people with these conditions as part of our research studies. So when is the early phase? At the moment, we don't have treatments to change the brain changes, but there are like some treatments that help with some of the symptoms, managing the symptoms, like for example, apathy, depression, etc., and that helps sometimes. Of course, the discussion is basically being very transparent with what we expect to see in the next few years with the family. Of course, everyone is very different, so each individual, what we suggest is no Googling. Like, for example, when we have a cold, we know that basically we are going to die in 2 weeks if we Google. The same is for dementia. Like, the Google is useful at a certain level, but you need to be able to filter the information, because sometimes a person with the same condition can live many, many years. Other people like live shorter, and there are so many different factors. So in terms of planning, it's just we try to be transparent with what we expect and try to see them every 6, 12, or 18 months based on the condition, and trying to speak with the family what is the priority for them and trying to help them. And also the diagnosis of dementia also helps to basically ask for support, professional support. So that helps as well. But yeah, it's very tricky because there are not treatments yet. And the big part of the research is something that we can offer to try to arrive to those treatments to contribute to the research, yeah.
Thanks very much again. Oh, a bit close. You mentioned at the start about I think it was Alzheimer's, 50% of the dementia cases, I think, and you were mentioning about amyloid treatment, amyloid proteins and potential treatment for those. But does the brain, the two questions is, could you mention a bit more about that potential amyloid thing? The other is, does the brain swelling start before the protein build-up? Oh. Does it cause a protein build-up?
There's a 1 million question, yeah. There's a very, very excellent question that we are trying to answer with our research. So just to give you a bit more context on the amyloid drugs. For many, many years, the main protein that everyone studied was amyloid, because it is very crucial for Alzheimer's disease, which is the most common type of dementia. In addition to amyloid in the brain of people with Alzheimer's disease, there are other things going on. And another protein that is very common is tau protein. So there are these two proteins that actually combined generate like the symptoms associated with Alzheimer's disease. And on top of that, inflammation. So because amyloid was for a long time studied, of course, we reached treatments that are trying to clean amyloid before anything else, because it was one of the first protein that was discovered in the brain of these people. There is a big debate on these drugs because they show that actually they clean amyloid. Like if you look at those brain scans before and after cleaning the amyloid with these drugs, actually the brain is clean. The problem is that this doesn't give much effect in terms of better clinical outcomes, or like it doesn't reduce too much the symptoms. And this could be that is because we just act too late, like the brain is full of amyloid and cleaning it is not enough because all the processes are already triggered, like the cell dying. Or maybe because we are not treating the right protein, and we need, in addition to that, cleaning also the tau and cure the inflammation. So we are trying to understand that, and there are also a lot of effect sizes with these specific drugs that are currently available in the US, not in the UK. They were approved in the US, not in the UK or in Europe. And for example, some of these drugs leads to, in some people, brain bleeding. So of course there is always like benefit cost. What is the risk? Shall we do that for reducing a bit of the symptoms, but not very much. So this is a bit the background of those amyloid drugs that I mentioned. Second question, very interesting, when inflammation kicks in, is before or after? We don't know, and that is the key that we are trying to answer. So there are some studies showing that actually is early on. It seems that the immune system stops working and functioning very well, and so the proteins accumulate. There are some other opinions that seems actually that the proteins start to accumulate, the immune system reacts, doesn't cope, and then creates a loop. Of course, for sure there is a loop, but we don't know what starts that. To answer the question, we need more longitudinal studies in people that are symptom-free, like, for example, those people with genetic forms of dementia, looking at both the proteins and inflammation, and it is what we are trying to start now, because until a few years ago, we didn't have very good biomarkers to look at all these aspects. Now that we have them, we can go early enough to look, over time, what happens first. But that's excellent question. That's the key question, because, we want to know the ultimate cause of everything.
I'm curious as to what drives the difference in diagnosis rates between men and women. Is it a menopause thing or a lifestyle thing or something else?
That's a very interesting question. So there are more and more studies in terms of sex differences and gender differences. That has been a quite understudied field. In general, I mean, women's health has been overlooked for many, many, many years. Now there is a compensation trying to put funding in that, like, for example, also in cardiovascular aspects, not just in the brain. There are differences. There are differences in terms, especially how fast they accumulated these proteins. They show that, for example, the accumulation of this tau protein is much faster in women than men. The symptoms are similar between women and men, but of course also the menopausal aspect that we know so little how this impacts actually the brain and these proteins that I think we just need more studies. But they are coming. Like I went to conferences in the last 2 weeks, and there are more and more centers, entire centers looking at that. So I think it will be interesting. But yeah, especially because, as I mentioned, in the UK is the leading cause of women over 65. So there is something that we need to understand why. Yeah.
Hey, if the amyloid and inflammation cause a vicious cycle which exacerbate the changes in the brain, do you expect that treating or trying to address the inflammation when the symptoms have already manifested would help? Or might that, like the amyloid, also be a case of it's too late?
That's a very good question. So what we showed, when I showed that graph of the steep decline in people with high inflammation, of course those people are already in the symptomatic phase. It's quite late in the disease. So what we think, if we act with anti-inflammatory drugs at that level, I think we can slow down the decline. So rather than declining so fast, you can buy some more years of quality of life, and it's very important also as a family to cope with the disease. I think at that stage it's very difficult that we revert to something that already happened, like amyloid, because amyloid, there are studies showing that they really start to accumulate 20, 30 years before the symptoms. So in terms of maybe it can stop other changes, like the breakdown of the communication between cells, but for amyloid it's probably too late. So we need to act definitely earlier on for that. Yeah.
Thank you. If you were trying to explain it to somebody who had no knowledge about any and all of this, could you say you need to do 3 things? Number 1, be as active as you can in whatever area. Number 2, concentrate on this on diet. And number 3, keep your brain really active by whatever. Is there a simple way to explain it to people who, including myself, who can't quite grasp what we best need to do to keep all this at bay?
Well, that's a very good question. So it's just thinking, basically, you can think like, for example, why do we care so much to keep our cholesterol low, right? Like when we do we test by blood the level of our cholesterol and we know that it's high, we know that it's bad, like for our body, we increment the risk of cardiovascular issues. It's the same for dementia, so ideally in the future we will have this kind of blood test that we can test and know at which level you are in terms of changes in the brain. But basically it's the same, everything that is, everything is bad for your heart is bad for your brain. We always say the same things you should eat healthy, move a lot, keep active. Something that is very important is actually socializing. They show that isolation is not good for our brain. We are social animals, so we really need to, that is one of the factors that actually is very important. For example, also hearing loss, if you can fix the hearing loss with some aids that help your brain because it keeps being stimulated. There are a lot of things that you can modify, like not smoking, for example, not drinking too much, eating very healthy food. At the same time, we also say, don't end up in a very strict life that you don't enjoy, because that is a recipe for disaster as well. So you need to enjoy your life as well, being balanced between these two things. But we need to really start to consider, because we have so many information on how we need to keep healthy our body, and we always forget a bit about our brain, because it's it's something that we cannot see. We cannot weight our brain. We cannot. We don't fit the pants anymore. It's oh, maybe I should just lower the sweets or something like that. The same is for our brain. We cannot see that, but we need to think long term, that everything that you do now, it is helpful for later in life. And being consistent with that, yeah.
Is there any correlation between activities that involve a degree of head trauma and then subsequent dementia? So, for example, sports like obviously boxing, but then at the more regular end of the spectrum, football, where you're heading a ball on a regular basis?
Yeah, that's a very good topic, actually. There is much more awareness in that field, and there are many, many more research studies into that. There is a lot of initiative in Scotland, for example, on the rugby side, and also in London for the football side. So basically what we know so far is that continuous trauma, concussions in the brain is not good for the brain, which is intuitive in some way, it's not great. But it's not great because in some cases they show that, for example, especially from the American football, they show that a lot of concussion could lead to accumulation of these junk proteins later in life. Again, we don't know enough. It's something that actually we started to be aware in the last decades, and especially from the box, because it's quite intuitive, the punching the brain in the front cause a very similar situation to frontotemporal dementia, because of course the brain is damaged in the front. On the other side, because we don't know how much strong is the association with all sports, we cannot, of course, stop everyone to play football, right? We need more information. And also, some of these sports, like football, for example, is good for the rest of your body because people exercise. So again, we need to find a balance of protecting the head while keeping exercise. And there are more and more studies trying to understand what is maybe kicking the ball with the head is they are trying to understand how to improve that.
I'm not sure how many other people I speak for here, but as I get older, obviously I get memory loss.
Yeah.
Is the process of memory loss through aging a sort of similar process but at a milder level than dementia, or is it something that is radically different? And what's going on? And when you do your control experiments against a healthy person, are you comparing it with people of the same age? Thank you.
That's an excellent question. That's a very scientific question, like how we reason to approach these studies. Absolutely, yes. We compare the similar age and sex in general to reply to the previous question. We're trying to correct for this fact. So in general, if we look at population over 65 of people with dementia, we also recruit healthy volunteers over 65. Intuitively, if you think people that run marathon in their 20s, probably they don't run marathon in their 70s. But there are some people that do that, right? But, you know, like the body, of course, ages, right? And the same is for the brain. And, of course, the way that the brain manifests the aging is losing a bit of performance. So, of course, we are not sharp anymore like when we were in the teens, so they are sometimes not very sharp, but, you know, like when we were younger. So, like, there is a level of normal loss of performance that you should not worry about. It is more like the differentiation between what is normal performance because of the aging and what is dementia is actually when these symptoms become daily life and stop the person functioning properly. That is an alarm in terms of like, okay, I need to worry that is something going on. And also because stress, very often people forget things because they have too much on their mind, so they are not functioning anymore in terms of executive function, for example, like making decision or, oh, I forgot the glasses, etc., etc. Again, you need to understand what is your context, what like is like just stress, is, you know, like normal forgetfulness, or is something that actually stop you to work in daily life. That is a symptom of dementia. It's very different, but yeah, like, yeah, it's our body and our brain decades over time, unfortunately.
Thank you. You mentioned about the PET scan being very expensive, mm-hmm. and potentially a blood test being available at some point. Do you have any information about roughly when the blood test might become available?
Timelines is always very tricky, because if I give you like exact numbers of years in those few years' time, you come, where is my blood test? So I think in the last 3 years, there has been what we call the revolution of blood-based biomarkers in dementia. So until really like even 4 or 5 years ago, we didn't have as many opportunities as we have now in terms of testing blood. In particular, there is this p-tau, it's called p-tau 217, which is a marker that actually captures that amyloid in the blood, and there are more and more studies that actually is quite consistent. So there has been this massive investment from Alzheimer's Research UK, Alzheimer's Society, and other funders to bring together 4.5 million pounds to start a research study across the UK to try to implement those blood tests into the population in terms of clinical work. Some of the tests are already in, some centers are already used to confirm some of the brain changes. Like, for example, there is a marker that we can capture in the blood that tells you if the brain is suffering in terms of cell dying. And sometimes people do that just because some symptoms could be related to depression and without structural changes or dementia, and some clinics use that as an extra informative marker. So I think we are not far. We are not far. We just need much more validation, because we need to be sure that once we have these blood tests, we are 100% sure that what we are looking and is not influenced by what we are eating, which period of the day we are taking the blood or something like that. So we are doing these studies at the moment to try to validate a very consistent, robust marker, but we are not far. Yeah, and once we have that, definitely there will be a lot of discussion about screening. How do we use that? For now, we are using that just when there are symptoms, so we don't go before. It's like if there is a symptom, do we want to confirm the diagnosis with this other test? They are saying that we are cutting, so thank you so much.